Welcome to Class 2. This is our first asynchronous virtual class, and this one's going to be on the normal newborn. So you guys will have a couple of hours to work through this material. You can pause it or stop it whenever you need a break. There will be some natural stops and breaks throughout as we go to some different video links that will be embedded on Blackboard that you can watch and then come back to the content, the theory content. But yeah, we're going to be talking about the normal newborn today. And I look forward to seeing you guys all in our synchronous class Wednesday mornings at 11 to go over and do some class activities and go into more depth on the newborn. All right, so what are our objectives of this class? Well, certainly we want to know as a nurse, what are some of the nursing actions, interventions, evaluations, the data collection, the assessments that we need to be doing with our newborns and our child rearing families? We need a foundational or understanding of fetal development right from preconception through conception, right through birth and after, in order to get that big picture about what could potentially be risks or could be impacting that new mom and babe. We're going to summarize some of the components of the newborn assessment. We're going to look at how newborns differ from adults, and we're going to take a look at some of those common newborn complications. We'll go more in depth with newborn complications next week, but we're going to focus more on just kind of our normals and what we would expect to see with a newborn, because there's a few of those abnormal normals that we sometimes see with the newborn. And just a cute little picture here to start off. I mean, this is adorable, right? I mean, how can you not just fall in love with that? Mom and babe, skin to skin. Right off the bat, I hope you guys are noticing a few things as a nurse that you would maybe take note of. Most likely just some of the redness here from laying skin to skin, and then maybe just move their head. There's some other red areas up here that may be signs of possible trauma we'd want to look through, or maybe they just haven't had a bath yet. But certainly want to. But this is the population we're going to be working with, and they're so much fun. So preconception, right from the get-go. How are we, from a population health, a health promotion perspective, how are we ensuring that our child-rearing women that are of age to conceive, how are we ensuring from a preconception perspective that they are already set up for the healthiest pregnancy possible? Because we know that the healthier our women are to start with, and the better outcomes we're most likely going to have with their newborn. So we need to have these health assessment questions and these conversations earlier rather than later. So are you talking with, anytime you're in contact with a young lady that's menstruating, have they looked at, are they thinking about getting pregnant? Are they sexually active? What kind of precautions are they taking? If they are thinking about getting pregnant, what are they doing to help pre-pregnancy, preconception-wise to have the best health? Are they taking supplements like folic acid? Are they protecting themselves from sexually transmitted infections? There's so, are they, do they smoke? Do they drink? How much alcohol do they drink? How physically active are they? What are their weight? Like all of that data collection and all those assessment pieces, they do come into play pre-conception as well as all through that pregnancy as well. So we're going to be asking all those questions, and you need to be thinking about that anytime you're working with young women of child-rearing age, and not so young women of child-rearing age, should be asking them about birth control, sexual activity, thinking about pregnancy, and just their overall general health, nutrition, activity, risk factors. Okay. And then we can't discount genetics. We all know some of us seem to have won the genetic lottery. It doesn't seem to matter what we've done, right? You can smoke and drink and laze around the couch and you'll live to be 100. But that's the outliers or the exceptions. And we know that genetically that there are people that are going to be more predisposed because of their family history and what's gone on previously that are more predisposed to genetic conditions. So maybe we want to know their family history. We not want to know if they've had any siblings or other children that have had genetic conditions. So just that whole data collection, getting that thorough health history so you have the context and that big picture that you can really support these families moving forward. So relevance in genetics to nursing, certainly we have nurses that just focus on genetics, that work with preconception counseling, that work with families after they've had some kind of genetic concerns, or maybe they've had a child, or they themselves have some genetic issues, maybe Down syndromes, maybe Fragile X, lots of different conditions out there that we want to set up counseling and supports to be working with this family and again getting all that information. And we need to let them know what's out there for genetic screening, testing, everything there. And supports if they have had a child and they have experienced a loss to a child, with a child at some point. And with that understanding of genetics and getting a good health history and looking at the family history, we also need to have a really good understanding of how the fetus develops. So we know that in this first couple of weeks, usually this point in time when people don't even know that they're pregnant yet, that there are possibilities for, you notice down here it says death of embryo and spontaneous abortion is common in this period of time, but often this is before people even know they're pregnant. So it might be they're a few days late and then all of a sudden their period starts, or maybe they get one of those really, really early tests and then find out they're pregnant, and then all of a sudden they start to have a menstruation cycle. So this is usually because genetically it just was not viable, right? And then as we move through the main embryonic period, we need to be thinking about what's developing during this period of time. So what part of the body is being developed? This kind of shows you here different areas. And then when are they most susceptible? And then there's a fetal period. So, and when are they sensitive to teratogens? And we're going to have a question on our class during our in-class activities, our synchronous class, on what are teratogens and what are some examples of those, and when are they most impactful to our developing fetus. So we'll talk about some of those things and look them up. All right, so you're working with somebody that is just found out they're pregnant or suspect is pregnant, and then we have to start looking at some of our prenatal screening. So in our first trimester, that first few months of pregnancy, there are some screening that we routinely do. We've got our nuchal translucency. We certainly have to look at our risks, and that's part of what we determine what they should be offered. But basically in the first trimester, we're really looking at the diagnosis of fetal anomalies. The goal of our trimester screening is to just, see if there is any possible, if they're at higher risk for some kind of malformation, or if there's something abnormal going on with the pregnancy. So in first trimester screening, they can have an ultrasound, certainly. They can look at nuchal translucency, which is where we will often pick up that Down syndrome. But there can be a 5% false positive rate, guys, so it's not always 100%. And even if they do first trimester screening, it's still recommended that we screen for open neural tube defects around that 18 to 22 weeks. So this first trimester screening is often done in that 11 to 14 weeks. Surprisingly, not everybody knows that they're pregnant at this point in time, but certainly this could be when somebody says, I know I've got higher risks. I this later in my life that I'm starting with having children. I know I've got increased risks of having a child with Down syndrome, and I really don't think I could handle that. So I would like to do as much screening as possible and testing at this point to see, so I have enough time to terminate pregnancy if this is not something I want to continue on with. So this brings up some real ethical questions about how you feel as a healthcare provider and what is your values and beliefs. Do you support somebody getting an abortion or terminating a pregnancy? So those are all those questions we need to be aware of as we are working through this. All right, second trimester screening, and I'm going to back up a little bit. So if you're working with somebody prenatally and you're talking about the different tests and you're explaining what they are and you're going through, the pros and the cons of the tests, I think the biggest question you have to ask them is, what is their philosophy? If they're looking at this testing and they do find something abnormal, have they thought about what they would do or where they would go from there? Now, some people will say, I don't want any tests because at the end of the day, this is my baby and I'm going to carry to term for as long as I can carry my baby. And however my baby's born is fine, and I'm going to deal with that, and that's the way it's meant to be, and that's okay. So they don't want any screening. Though a lot of people will say, I want the screening, I'm still going to have this baby no matter what it shows. But I'd like that opportunity and time to get prepared and prepare myself mentally and, get the supports in place. So certainly I would encourage our families to take advantage of the screening so that they can get those supports in place and be as prepared as possible. And then our second trimester screening, we can certainly look at, so our maternal serum alpha fetal protein is to look for some of our neural tube defects, okay? And it can be done with reasonable reliability between 16 and 18 weeks. And if it's abnormal, then they might look at amniocentesis, okay? But there's some benefits and risks to that as well. Then we can look at our triple marker tests, and it can identify some Downs as well. And then we do our routine ultrasound at 18 weeks. Okay. And a lot of times we'll often do these, especially these non-invasive tests, because then it can say, do we want to go on to the more invasive tests? So the previous were screening tools. Now we're moving into the actual tests. So these have a little bit more reliability behind them, but there's a little more risk as well. So if we go chronic villus sampling, there is slight risk to the fetus because they're certainly going in with the needle and they're taking some samples out. Takes a small tissue specimen from the fetal portion of the placenta. But small risks, some complications to mother and fetus can occur in about 1% of the cases. Okay. And amniocentesis, basically they're going to the amniotic fluid. So again, both of these have some slight risk. And then the other question you have to be thinking about is if they are thinking about terminating, the earlier we know, the better, because the farther along we get, the more problematic termination can be. All right, now we've got to look at our risk with maternal age. So I'm thinking you guys all figured out, and from our previous our introductory class on trends and issues, that there's certainly increased risk with increased maternal age. And here's some of our risks. So we should offer all pregnant women the non-invasive methods of screening, like our first trimester screening. Our other screening tools that we'll use is as we move on into the third trimester is we can do non-stress tests and we can do fetal movement counts. And at this point, first first and second trimester, we're really looking at the diagnosis of fetal anomalies. But now that we're moving into the third trimester, we're really trying to see, is the intrauterine environment optimal for growth and development for this newborn? So are they growing well? We're trying to rule out if there's any uteroplacental insufficiencies. Okay. And some of the screening we'll do is our biophysical profile. So our biophysical profile is when we use ultrasound and we do a very detailed assessment, the physical and physiological characteristics of the developing fetus. So we can really basically get a really good look at that developing fetus. It can be done with or without a newborn non-stress test. But if it's done with a non-stress test, so the non-stress test is where they put the belts on and they actually look at the heart rate of the baby and they look at the fetal movement. So the mom has, I'm sure you guys have all seen it, the moms are kind of strapped up to the machines and they are monitoring the heart rate and movements. So a biophysical profile score of less than 6 is an indication that we should get that baby out, especially if there's oligohydramnios. But when the biophysical score is normal, so when we're looking at it's out of 8 if it's done without an NST, and it's out of 10 if it's done with an NST. So the higher the score, the better. So you're kind of looking for the 10. Okay, and this next slide has a breakdown. So what are they looking at? So they've got ultrasound on, and they're looking at breathing movements. They're looking at movement. They're looking at tone, and they're seeing how much amniotic fluid there is. So they've got the ultrasound on. They're getting that visual of the newborn, and then they're getting a score. And it's done over 30 minutes. And like I say, it's out of 8 if you didn't use a newborn stress test, or it's 10 if you did hook them up to the machines. All right. And what are some of the things that can impact the newborn again? So when we're talking about preconception, we're talking about evaluating the newborn and that we're screening and testing for different things, is we're certainly looking at teratogens. So I'm going to kind of ask you guys, what is a teratogen? And a teratogen is anything in the environment that can impact the growth and development of a developing fetus. So when we go back to that slide where it showed, the different ages when they can be impacted, we certainly know that approximately 3 to 4% of all live births can be impacted by a birth defect. And a lot of them are caused by teratogens. So there's so many different, how many pregnant women don't want to take any kind of medication because they're worried about what effect it'll have on the newborn? When we're working with this population, we definitely want to be working with the families and talking to them about what could impact smoking, alcohol, protecting themselves from infections. We don't even know about COVID yet and how much impact it may or may not have on the developing fetus, but it's probably fairly similar to influenza, right? So any kind of viral infection can potentially impact the growth and development of the fetus. So there's so many different things that can impact. Marijuana is a big one that we've certainly been looking at lately, right? Because it's now legal. So what do we know about marijuana? Well, is it considered safe? If somebody asked you, you're working with a pregnant woman, and she said, is it safe for me to use marijuana? And you're going to tell them, no. We do know that it crosses the placenta, but we don't really have any concrete research to prove how negative it may or may not be. And it's often because if somebody's smoking marijuana, are some of the negative findings we're finding because of the fact that they're smoking, or is it because of the marijuana? But we have other research that says that there is a negative impact on neural functions and brain development with any kind of marijuana used with young children. So definitely want to avoid it in pregnancy. All right, so we're going to pause here. I'm going to stop here, and then you guys will have this link either in your PowerPoint. You go through it, or you can, or I'll have the link in Blackboard. Actually, we'll just go with it in your PowerPoints. That's easiest. So you can copy and paste, or you should be able to click on that link and watch this video.